Okay, so let's take a look at this next case, case 23 in the cardiovascular section of this book. First aid cases. A 35-year-old woman presents to her physician complaining of fatigue and fever. She has lost 7 kilograms or 15 pounds over the past 2 months and also reports occasional abdominal pain, headaches, and muscle pain. On physical examination, her blood pressure is 154/92. Retinal examination reveals cotton wool spots, and skin examination is notable for palpable purpura. Laboratory studies showed an erythrocyte sedimentation rate of 121, and an enzyme-linked immunoabsorbent assay, or ELISA, is positive for hepatitis B surface antigen antibodies. Okay, so this person has polyarteritis nodosa with palpable purpura and other common symptoms such as weight loss, inflammatory markers, and evidence of vasculitis in her retina. So next we're going to ask, what is the pathophysiology of the disease? Polyarteritis nodosa is an autoimmune disorder characterized by segmental transmural inflammation of the small and medium-sized arteries due to necrotizing immune complexes. The next question we're going to ask is, what vessels are involved? And the answer to that is the vessels supplying the kidneys, heart, liver, and gastrointestinal tract are those that are most involved. Next question is, what laboratory test can help establish the diagnosis? So the answer to that question, what laboratory tests can help establish the diagnosis? The presence of perinuclear anti-neutrophilic cytoplasmic antibody, or p-ANCA, correlates with disease activity. p-ANCAs are more commonly seen in small artery disease. Furthermore, antibody testing against hepatitis B may strengthen the diagnosis, as approximately 30% of cases of polyarteritis nodosa are associated with this infection. The next question we're going to ask is, what other small to medium vasculities could this patient have? So let's ask that question again. What other small to medium vasculities could this patient have? Churg-Strauss syndrome is a variant of polyarteritis nodosa characterized by eosinophilia and asthma. Autoantibodies mostly target blood vessels in the lungs, but in the late stage, other organ systems can become involved, including the skin. Wegener granulomatosis features ANCAs that damage blood vessels in the upper respiratory tract and kidney. However, it can also involve joints, skin, and the GI tract. So what complications may be seen in polyarteritis nodosa? So regarding the complications, inflammation of the small and medium-sized arteries induces a local state of hypercoagulability. This may lead to thromboses and subsequent ischemia or infarction of distal tissues. Unfortunate individuals have suffered strokes and heart attacks, but ischemia is possible in any organ system. Damaged arteries are at risk for aneurysms. So the next question here is, how would you treat this? And the answer is prednisone and cyclophosphamide. If you treat with prednisone and cyclophosphamide, this produces remission or even a cure in approximately 85% of affected individuals and prevents these complications. So there we have it, just reading case 23. So good luck.